we go. Hi, and welcome to week 1. All right. As you notice, I call this the postpartum family because it's not just the mother and the baby, it's the whole family that we're taking care of. You'll hear it time and time again throughout my lecture, during clinical time, that we are guests in a family's memory when we walk into their room in the hospital or in any other setting. So I start everything off with that key word, and that's family. And the reason I start with the postpartum period, it's kind of like putting the cart before the horse. The reason I start with postpartum is because the majority of our patients that we're going to be caring for in the clinical setting are postpartum. Labor and delivery, there might be 1 or 2 of you that get to see labor and delivery each week, but the bulk of you will be taking care of postpartum. So I do postpartum and newborn, and then I go back to pregnancy, labor and delivery, and we take it from there. Does that make sense? Okay. So that's my deal on that. Family-centered care. We've been doing that pretty much in OB for a whole lot longer than the other areas of the hospitals. But it really is important to include everyone involved in your assessments, in your education, especially in your discharge teaching and stuff. It's really important. We no longer have that nursery that the father can come to and like look in the glass and wave to their babies from the other side of the glass. Those babies are really spending the majority of their time in the rooms with mom and dad. It's important in terms of them getting used to their baby before they go home 2 days later. And a lot of our patients just say, they took my baby and I didn't know where they went for a long time or whatever. So you will not see nurseries in the 3 places that we are at. There is no well baby nursery that has babies in it for very long. Maybe for some testing or whatever, and they need a quiet environment. But other than that, they're out with moms if they are well. So it's all about, oh look, I even wrote it there. We are guests in this family's memory. Make it a good one. Have you talked to like an old person, say like me, you ask me questions about my birth experience? My daughter's 26 years old. I can tell you as if it was yesterday, everything I felt, everything I experienced, because that is an important moment in my life. I gave birth amongst my coworkers, so that's fun. But other people can tell you they're not necessarily the name of their nurse, but if she loved her nurse or did not like her nurse at all, they will know and remember years and years later. So keep that in mind, and whenever you interact with a patient, and in this arena, it's no different. In fact, maybe even a little bit more so, because there's not necessarily the stress of a sudden illness or anything like that. They're anticipating a very good experience. All right, chapter 17. I've tried to narrow this down for the people who insist on knowing what chapter it is. The postpartum period is actually from the delivery of the placenta through the first 6 weeks of motherhood. All right? Lots and lots of changes, or adaptations, if you will, going back to pre-pregnant state or non-pregnant state. We'll talk about the physical and psychological adjustments. The 4th stage of labor is actually the first couple of hours of this postpartum period. All right? 1 to 4 hours. The first stage of labor, just for your purposes, perspective, is labor itself. The 2nd stage is pushing to get the baby out. The baby comes out. The 3rd stage is waiting and the expulsion of the placenta. 4th stage is after that placenta's out, those first few hours of close monitoring. The main or primary goal of this time is preventing postpartum hemorrhage. And that's the primary goal, but honestly, there's a whole lot more in terms of education and making them comfortable and keeping them safe. All of that has to happen in those first few hours. So physiologically, as I mentioned, there's a lot of change, all right? There's changes in the uterus, and I'll give you numbers to demonstrate how much the uterus changes during pregnancy, so that it makes sense that all of that has to go back to non-pregnant afterwards, like the volume expansion and stuff. I think it's pretty incredible. So we're going to talk about uterine involution, which is that going back down to non-pregnant. The lochia flow. Lochia is vaginal bleeding after you have a baby. Why we can't call it vaginal bleeding after you've had a baby, and we have a special name for it, is your guess. I don't know why. Just as the uterus has to go back down to normal, so does the cervix. The cervix is the opening of the uterus at the top of the vagina. That has to kind of close back up and mend, if you will. The vagina has some work to be done after a delivery, a vaginal delivery, to kind of go back to a new normal, we'll call it. It's amazing how much that vagina takes. Every time I see a vaginal delivery, which by the way has been thousands, I'm watching, I'm like, whew, wow, I didn't think you could do that. And then it kind of goes back to almost the way it was before, almost. That's why I say the new normal, all right? Nature is pretty incredible. So we'll talk about that. Hormones, ovarian function, all that. Cardiovascular, lots and lots of changes during pregnancy and following delivery. We cannot take for granted all of those changes. In fact, underlying cardiac issues might actually rear their ugly heads during the postpartum period, because there's a lot of stress on the heart and cardiovascular system as a whole. GI, GU, we'll talk about, and as I mentioned before, with ovarian function, hormones, and there's other hormones too that play a role. So we come in, we have to do a postpartum assessment. The first thing we really should ensure is privacy for the patient and permission. Privacy and permission. All right. Most of our patients are healthy and stable if we're going in to do a postpartum assessment, which means hopefully we can have a little flexibility. All right. As I mentioned to my clinical group the other day, if great-grandpa walked in right before me to meet his very first great-grandchild, who the heck am I to say, excuse me, sir, could you please step out for a minute? Like moments after he's walked into the room. Get it? Remember that whole family, we're guests in their memory? If we can be flexible, which means the patient, we're reported that the patient is physically stable. All right? We might say, are you comfortable? Is there anything that you need? All right? But don't interrupt the family moment if we can. Say, tell you what, how about I come back in 10 minutes? If we can do that, I think that's really important. And a great first impression for the family that you're caring for. Postpartum assessments, we're talking about looking at and touching some pretty personal spaces, all right? So ask permission. And not like, may I touch your breast, please? But is it okay if I take a look at da-da-da? It's just the right thing to do overall. So privacy and permission, very important. Also, do not assume that the young man sitting next to the patient in her bed is her husband. If you start talking about sore nipples, you very well might traumatize her younger brother. All right? Just lesson learned, folk, lesson learned. And don't assume that the gentleman, the older gentleman in the corner is your dad, because that might be your husband. No. So don't assume that the people in the room, like even if it's her mother, then she might not want her mother in there when I'm talking to her about her hemorrhoids. So take it on yourself. Don't put the patient on the spot. I say, I'm just going to ask everybody to just step out for a moment when it's the right time. Just step out for a moment while I do a quick exam. And then the patient can say, oh, no, that's just my mom and my husband, they can stay. Does that make sense? Very subtle difference between, would you like me to ask your mother to leave? Well, we don't need to piss off mom, right? All right. So we're going to do that. We're going to make sure mom is as physically and emotionally comfortable as possible before we start the exam, which means if she's very uncomfortable physically, she's probably not going to be able to give you the best information, and we might have trouble assessing certain parts of her body while we're doing it. I take every moment I have with my patient to do education and provide information. We have 2 days, maybe 3 if they've had a C-section, to provide enough information so that they feel safe and comfortable going home, taking care of themselves and a small creature that they might have never taken care of before. So education is huge in the postpartum setting. All right, and it's I would say our number one priority, other than keeping the patient from bleeding to death. All right. Document. I don't think I need to go through that anymore. And there are a lot of body fluids flying around in the labor and delivery area. And before a baby has had a bath, they're covered in body fluids as well. So universal precautions is important. So the bubble assessment, I don't know. People like to have catchy little phrases to remember, right? It pretty much just takes you down the woman's body. We're going to talk about our breasts, uterus, bowel and GI function, bladder, lochia, that bleeding, and episiotomy, all right? We'll go through each one separately. Breasts, I usually say, how are your breasts feeling? Are they starting to feel full in terms of milk, your milk coming in? If she's the first day postpartum, then she probably has not any difference of feeling with her breast. But if she's like day 3, she might start feeling her breast getting full because the mature milk comes in day 3 to 5. So there's that. I also ask about how her nipples are feeling. And it's not just a curiosity. It is, who's breastfed? All right, I don't know about you, but I was not used to that amount of strong suction for so long on my nipple. All right? Ow. They need to toughen up a little bit. I have seen pink tinge tender nipples, and I've seen what looks like raw hamburger meat, like blisters, splitting, cracking, bleeding. Yeesh. Yeah, so it's a skin integrity issue, right? So I ask about it. How do your nipples feel? Are they feeling at all tender? And if she says, yeah, the right one hurts a little bit, when I say, do you mind if I just take a look to see if there's a blister forming? All right? Skin integrity, doesn't matter what part of the skin, right? We have to note it, we have to document it, all right? And we can maybe refer the patient to lactation consultant services, talk about, ways to counteract the tenderness that they might be having. Like I said, just take every opportunity to do the teaching along the way. Talk about wearing a properly fitting bra, which they should always have that on. That kind of keeps everything from getting out of control. All right, a nice firm fitting bra. That colostrum is the milk that's there the first few days. In fact, some women leak colostrum out of their breasts in the last trimester of pregnancy. It's low on volume, so they don't feel like there's a lot of milk in there, but it is high in nutrients. I call it mother's gold, all right? Very, very important for the baby to get, and very important for mom to be reassured that it's normal to not see a lot. Yeah?
So the colostrum is the initial on?
Mm-hmm.
Like the first day after birth?
The first few days.
The first, the 2 or 3, okay.
Mm-hmm. I just looked down and I saw this like big fat green thing right here. I was like, oh gosh, hi. This isn't such a good idea.
So does the real milk come on the 4th day, average? So then it's the colostrum.
I still like to say day 3 to 5, depending, day 3 to 5, because some women who have breastfed before, their milk might come in sooner.
Got it.
It's a supply-demand system too, so maybe things get flowing better if breastfeeding's going really well.
Got it, okay.
Yeah. Everyone's different though. All right, uterine involution. Involution is the process of a uterus that was this big going back down to a uterus that is this big into your pelvis, all right? It begins immediately after the placenta delivers. And it takes 6 weeks. It does take 6 weeks, all right? Right after the placenta comes out, it does a lot right away. And it goes from probably right below the ribs here to the belly button. The top of the uterus, which we call the fundus, is about at the belly button. That's where we want to see it. And every day or every 24 hours, we would expect it to drop down like 1 to 2 centimeters in her belly every 24 hours, okay? And you can do the math. By the 6th day, it's halfway down, and by the 10th day, it's probably no longer you can no longer feel it because it's back into the pelvis the way it should be. It has not stopped. It's changing, but you can't feel it anymore. That's kind of what we're doing when we're feeling it. You support the lower belly, and we feel it with our fingers. It should feel like kind of like a grapefruit or an orange when you poke at their belly a little bit. And we want it right in the middle of their belly, right? Centered on their belly button, basically. And like I said, it should be in and around the belly button on the first day, 1 to 2 centimeters each, lower each day. All right, so if you find it like 3 or 4 centimeters above the belly button, or if you find it like way over on the right side, there's issues, all right, that we need to just address. And we'll go into those details. What we're looking at is where is it, and is it nice and firm? We want it nice and firm, all right? Think about, and it might be on the next slide. I'm not very good at that. All right. Think about where the placenta is in a woman's, inside the woman's uterus. Placenta comes out. Prior to delivery, that placenta was richly supplied with a lot of blood vessels and blood. Am I right? I should hope. Placenta comes out, that is an open wound. Most recently, richly supplied with a lot of blood vessels. So what do we want? We want that uterus to clamp down and pinch off all those blood vessels. Does that make more sense when you think about you want a uterus that's nice and firm? We don't want them uncomfortable, but we want that uterus pinching off all those blood vessels. So if the uterus is not nice and firm, you would expect more bleeding, okay? There are some factors that might interfere with it being nice and firm, and we'll talk about each one of those. I like to call it a uterus that is tired, confused, or pushed around. I don't know if that makes sense to some of you, but tired is a uterus that had to push out a 10-pound kid. All right? How about a uterus that contracted for 27 hours before delivery or was on Pitocin for 3 days? How about a uterus that had a big kid but also had a lot of extra amniotic fluid, right? Do you see where I'm going with that? Tired is also a uterus that's done this several times before. My great-grandmother had 19 children. My grandfather was the last of the 19. My guess is that he just handed her uterus to her on his way out. I don't know. That's a tired uterus. I mean, tired probably overall, but I don't imagine she had an easy time of it after that 19th baby. I know. I did meet her. She was 97 years old when she died, leaving 97 direct descendants. That's a big family for, one woman had 97 descendants at the time of her death. That's pretty cool. I was scared of her, though, but anyways, she was a shriveled up old lady who didn't speak English. She was nice, though, I guess. Anyways, 19 kids. That's a tired uterus, folks. I'll go to pushed around uterus. Let's think anatomy-wise. We have a uterus, and in front of the uterus is a bladder, all right? During the end of pregnancy, that bladder is what, about this big, right? Because the big uterus is kind of bullying it a bit, right? So baby's out, placenta's out, uterus is starting to shrink down, bladder has all this extra room, right? Hormonally, muscle tone is a little decreased after delivery, so sometimes a woman does not feel the urge to void when she has a full bladder. But if you're now thinking again, bladder's on top of the uterus. So we got a full bladder pushing on the uterus, all right? We want the uterus, this is why I have to videotape my lectures, because this is when my hands start flying. All right, you want a uterus to be nice and tight like this in a ball, right? All right, well now you have a bladder pushing on this nice tight ball. So it's pushing it like this, and pushing it out of the way like that. Well, you can't stay nice and tight like a ball if you're getting pushed up and over like this. So you're gonna bleed and it's not gonna stay nice and firm. What you're gonna find when you go to feel for the fundus is that it's not at the belly button right in the center. It's higher than the belly button and over on the right. That is a telltale sign that there's a full bladder pushing it up and over, okay? That's a pushed around uterus, folks. Confused uterus. The placenta and the products of conception, if you will, the amniotic sac and the cord and all of this, send signals to the cardiovascular system to supply blood and keep those blood vessels pumping blood to the baby, all right? I believe it's magic, but maybe it has maybe hormones have to do with it. But I'd like to say it's magic. It's probably hormones, whatever. So say a little piece of something gets left behind, right? Baby's out, placenta's out, but there's a little chunk of placenta that kind of got stuck in there, all right? Well, the magic continues. The signal gets sent to keep supplying the uterus because that's the job, part of the job of the products of conception to do. So it's getting mixed signals. Like, okay, I'm supposed to, but I'm not. But that's a confused uterus, okay? Confused uterus is gonna maybe sometimes contract, maybe sometimes have some extra bleeding. It's just confused because it's getting mixed signals. The body's getting mixed signals. Make sense? So we've got a tired, confused, pushed around uterus. That's one that will not stay nice and firm, and you'll see increased bleeding. Or this stuff. But I think I've pretty much covered it, right? Consider also the oxytocin, which for those of you who've taken the med exam, manufactured oxytocin is Pitocin, the drug we give. Oxytocin is actually a naturally occurring hormone in a woman's body, is from the pituitary gland, all right? And it is responsible for strengthening and coordinating uterine contractions. Breastfeeding stimulates the production of oxytocin. I had I was a nurse in an OB office, and I was an OB triage nurse. And I told a couple to come to the office instead of going to the hospital because their story didn't impress me. Not impress is the wrong word, but I just wasn't sure she was in labor. And I didn't want her to get all the way to the hospital when the office was on her way. Just wanted to check her out and see if, bring the stuff for the hospital, but let's just see if you're really in labor. Well, she was, and by the time she got there, she was 8 to 9 centimeters. So we delivered the baby in the office, which I was the only one quite thrilled about it. I had the office manager tell me, you really should have sent her to the hospital. I'm like, oh, you think so? Sorry, manager with no clinical experience. It's not something I do all the time. If I really didn't know, I probably would be delivering babies in the office all the time. This one fooled me. But I had fun anyways. We delivered a baby in the office. And I wanted to make it still a good experience for this family who, so far, we're batting 1,000, right? She did not get her epidural, though she was asking for it. She delivered on a stretcher, askew in the room, with EMTs like waiting out front, and like the entire office staff like wide-eyed in the hallway. And me and the doctor, I'm like, come on, I'm trying to keep it like how I would treat her if we had everything we needed in the hospital. And then as the baby was, I guess, between contractions, I'm like, so are you going to breastfeed or you're going to bottle? Oh, I'm going to breastfeed. Okay, all right. And the office staff like, really? Couldn't you just get that taken care of at the hospital? Baby comes out. I put the baby immediately on mom's chest. Placenta is coming pretty soon after that. And I'm like, do you want to breastfeed? How about we start breastfeeding right now? And everyone's like, get her out of here. And I'm like, no, let's breastfeed. So I'm getting her breastfeeding and everything's great, right? And people are like, what are you doing? I'm like, we don't have any Pitocin in the office. We didn't have that medicine to help me in case this uterus decided to, right. So I needed to get it in other ways, which meant she needed to breastfeed so that her body created that oxytocin on her own. And I made it seem like this was just normal. This is all normal stuff. I'm just concerned you're going to have a hemorrhage on me. All right? So let's just pretend like we do this all the time. Life is good. Nice little family moment. Breastfeed. Everyone was happy. The office staff thought I was crazy, but then afterwards realized that I actually was thinking ahead. The doctor didn't even realize, ooh. I'm like, we don't have you seen Pitocin around here? Ooh. I don't have Pitocin, but I can offer you an HPV vaccine. I got there, right? Bottom line is, patient's bleeding. We might be giving her medicine that is manufactured, the natural form of a drug or a natural form of a hormone that we could get by natural means. So breastfeeding is a wonderful way to counteract a postpartum hemorrhage. All right. The other thing we have to do is massage the uterus. And we're not talking like a spa trip, all right? We're talking the circular rubbing, which feels a little violent, all right? Because who's had this done to themselves, right? Ow, right? It's not fun, especially if things are not going well. They're in there like mashing on your stomach, right? So it's called massaging. Excuse me, I'm going to massage your uterus right now. Oh, okay. Ooh, what are you doing, right? It's not something you'd pay for at a spa. So it's this circular rubbing of the top of the uterus. And that's to irritate the muscle of the uterus, to contract as well. Sometimes it pushes out clots that might be forming to get in the way or whatever. So we're gonna get some oxytocin, whether manufactured or naturally in the body, and massage that uterus. If the massaging doesn't help, most times now, provided you are in the right place, we do have medication. So, and most women now have an IV running by the time they deliver, if they are in the hospital. So we usually add some Pitocin or Oxytocin to the IV fluids after the placenta is delivered, just to kind of give them a little head start. So just because we want to avoid a hemorrhage, all right? So we might just give them a little dose of Pitocin to get them started, all right? If the breastfeeding and the Pitocin in the IV and the massage doesn't work, we have some other drugs that we can try. Methergin or methylgurnovine, whatever that word is there. Methylgurnovine maleate is a drug that we can give IM or PO. And this drug, it's kind of like I said, the second line of defense to help with the contracting of the uterus. The thing about Methergin is that you cannot give it with hypertension. So that's probably something you should know. Hemabate is another drug. It has its side effects, though. I don't see Hemabate given as often anymore, but it certainly is a drug that we might give. If a doc is asking for Hemabate, we've already tried a couple of things, and things are not looking good in that room. So, yeah, Hemabate is your next drug. Cytotec or misoprostol is rising in popularity in terms of a drug that's used. Sometimes, actually, we might give the Pitocin, and if we need more of a dose, the doctor might actually ask for Cytotec next. All right. This is a pill that can be given PO. It's actually, I think, a cardiac drug. But it can also be put in the vagina, up by the uterus. More often is actually put in the rectum, right up against the uterine wall in the rectum. Because if there's a lot of bleeding, you could put a pill up by the uterus, by the cervix, but it's probably just going to get washed away. Yeah.
So does it mean it's a suppository then?
It's not. It's a tiny little pill, yeah, that they will put in there, yeah. Hi, sorry, we're massaging you and doing all these things. I'm just going to stick this pill in your butt. Yeah, no, it's a good time for everyone. Good time for everyone. Yeah. But it's actually probably the most effective means of getting that medication to that muscle right away.
Well, these are all just to help with contractions.
These are all just to get the uterus to contract after delivery.
In order to stop hemorrhage.
Thank you. We use Pitocin to induce labor for contractions, but we are very, very specific and very, very controlling with the amount that we give, because it can be a dangerous drug if the woman still has a baby inside of the uterus at the time. All of these drugs do have adverse effects, so we want to just monitor them closely, and certainly how well it's working in terms of their bleeding. As I mentioned, encourage early breastfeeding. That can't hurt the process. All right. If we talked about the old, confused, pushed around, all right. So keep that in mind. What do we want to do? We want to keep the bladder empty so it doesn't get pushed around. And again, if it's an epidural that the patient had, she might not also be able to feel that she's a full bladder. Between that, the decreased tone, and all the extra room the bladder has now, we may have to say, let's try to go to the bathroom. Well, I don't think I really have to. Well, let's try anyways. And they surprise themselves like, oh yeah, I guess I did have to go. Yeah. So assist at least every 2 to 3 hours postpartum, all right, and encourage her to get up and go to the bathroom. In terms of bowel GI function, bowels are also a little sluggish after any form of a delivery, all right? Back in the old days, we used to keep a patient in the hospital until she pooped. We don't anymore because they could be there for 3 or 4 days, and that's not good for your numbers, all right? So we do encourage them to increase their fiber. We might give them a colace pill. We encourage ambulation and drinking a lot of fluids and all that stuff. I also have to tell several new moms weekly in my life, I have never, ever had a patient pop a stitch by pooping. I've never had it. I've never had somebody pop their stitches from pooping. They feel like they're going to, every one of them, but it's never happened. Constipation has happened, though, and it's not fun. It feels like you're delivering another baby. For those who have had it, you're nodding knowingly. So you got stitches, you got hemorrhoids. These are hemorrhoids. This is the best picture of hemorrhoids I've ever seen. All right, I'm sorry if you can't get that really good on the video. There's a bunch of angry old men, like circling around, right? That says hemorrhoids to me. I don't know about anyone else. So with all of that going on, sometimes we're giving mom pain medication, like opioid pain medication after a C-section. She's just asking for trouble if she doesn't increase fluids, increase fiber, take a colace, move around, and poop when she feels like she has to. All right, like I mentioned, the bladder function is really important. Sometimes if a woman says, oh my gosh, I'm getting up every hour to pee, well, does it feel like you're emptying your bladder? Is it just a small amount that you're going? Is there any burning pain? You don't want to make sure she doesn't have a UTI. Check her, check for those things. But if in the absence of other symptoms, peeing a lot is normal. A woman has 1.5 times the blood volume starting in about the 3rd trimester of non-pregnant. Yeah, most of that's plasma. So after delivery, we've got to get rid of half the blood volume, or a third of the blood volume, or whatever it is. I mean, a lot of extra fluid is on board naturally in terms of body fluids, but also we might have given a couple of bags of IV fluids and all sorts of things, right? So it's natural that they might pee a lot. It's naturally occurring diuresis, all right? In the absence of any other symptoms like burning pain or urgency that is, any UTI symptoms. In the absence of UTI symptoms, if it's 12 to 24 hours after delivery and she's complaining of peeing a lot, you can bet it's diuresis, all right? That's probably fairly important to remember, say, in 2 weeks' time. 1,500 to 3,000 milliliters a day can be peed out by a normal, healthy new mom. All right? But if she feels like she's not emptying her bladder, but she's done her best, we should, a lot of postpartum areas have bladder scanners to look because there could be a retention issue that we would want to follow up on. It's, as I mentioned, the loss of tone. There could be an injury to her bladder. Say if she had a C-section, they might have, moved it around a little bit too much. So the frequent voiding of less than 150 milliliters each void might indicate that. And as I mentioned, a uterus gets pushed around pretty easy by that bladder. That bladder, quite frankly, is a little pissed that it got pushed around for 9 months by the uterus. And now it's their turn. all right? They're like, oh, let me show you what I can do to you. I'm just kidding. I'm putting emotions to inanimate objects. Bladder tone will return with close attention within a week postpartum. Lochia. As I mentioned, lochia is the vaginal bleeding after a delivery. It's the bleeding from that open wound that is healing, as well as the lining or the decidua of the uterus that has built up during the pregnancy. We care about the color of it, the amount of it, the smell of it, and if there are any clots. Yeah. Well, if it's really foul, it smells like blood, which has an odor to it, but it shouldn't have a foul odor to it. If it's a really foul odor, that could be indicative of an infection of the lining of her uterus, all right? We probably will see like a slight fever at least and some malaise with mom if it were, a full-fledged infection. But certainly we want to note if it's a foul smell. The color, why we can't call it dark red, I don't know. We call it rubra, all right? Lochia rubra. Pinkish, when it starts lightening up, we call it lochia serosa. And after the first 5 or 6 days, it's just a faint color pink. And then it looks like it's gone, but it's actually white. We call that lochia alba, all right? 2 weeks, I would say, is the most common amount of time that there's any sort of vaginal bleeding / discharge.
So for all of them, from the rubra down to the alba?
Yeah. Alba's not easy to see, like on a pad or anything, but it's still there.
So is it like completely white or like more clear?
I don't know. I've never put it in my hand. It's
Usually when there's white discharge, it's really like warning.
Right. I get it.
Obviously, OB is different.
OB's different. If she's weak postpartum and she has a white discharge, I'm gonna assume it's lochia alba, minus or in the absence of other symptoms. If it looks like cottage cheese, and she wants to take the bottle brush to her raw vagina. Sorry, do you like cottage cheese? I apologize. So sorry. All right. Then I'd be concerned. I would be concerned, but yeah, in the first 2 weeks or so afterwards, I would assume it's a lochia. Thank you for that question, because you're right. At other times, a white discharge might not be normal. Some women complain of clotting, like, oh my gosh, I passed a whole bunch of clots. And I always say, well, are the clots bigger than a golf ball? They're like, no. It's like the size of a raisin. I'm like, oh, all right, cool. That's fine. I'm like, oh, golf balls. So what happens is there's just some active, small amount of bleeding that happens throughout. Right? So a woman is laying down, maybe she's taking a nap or she's just resting, right, for a couple of hours. The bleeding still is coming, and it might just kind of collect in a little fold of her vagina, and then she gets up, and a clot has formed in that time, and out comes a bit of a clot. Perfectly normal, as long as it's not followed by a large gush of bright red blood, which means the clot is like came off of some major artery or something like that. So clotting like that in the first day or so is perfectly okay, and because of that reason. I have had a patient, you'll be impressed with this story, I'm sure. Did you hear that I tell stories? Anyone here that I might have a story or two for you? That's why it's important to have an instructor who's had 30 years. I have 30 years of stories to tell you, and I'll tell them all, which is why this class is so long. Yeah. Well, do you have anything else to do after class? I used to teach the Manchester crew on Thursdays. So I would be in Manchester all day and then teach class all evening. And I don't have to do that anymore, so I'm pretty well rested and feeling pretty good if you want to stick around. Sorry. Where was I? Clotting. All right, so I had a woman who, she was fine, she was stable, very little bleeding at the beginning of my shift. I worked overnight. This was when, I don't remember if the baby was with me or not. Either way, tucked her in, she was doing just fine. About 4 or 5 hours, maybe 4 hours later, 3 hours later, something like that, in the middle of the shift anyways, she calls in extreme pain, like major cramping. So I go on down and I go to feel for her uterus and it's like way up, still in the center, but way up in her belly. And she tried to pee and she, that didn't help. She just felt really, really bad. Lots and lots of cramping. So I feel this uterus way up here and not too firm. And I start doing that massage thing. Massage. And out comes an eggplant-sized clot. Like that nice juicy eggplant you like to parm up. You know what I'm talking about? It was the inside of her uterus. It had blood. Oh, did you like eggplant? It looked like eggplant. It looked the shape, the size, and kind of the color too. Yeah. Sorry.
You're just ruining like all food.
Yeah, that's what I do. But it really was something was blocking, it was actually a small clot, was blocking the opening, the cervix. So nothing was coming out of her uterus. It was all, the blood was just backing up into her uterus. That's why, finally, she woke up in that pain. And after that eggplant came out, at first I was like, oh my gosh, is this another baby? Like, it was dark, it was like 2:30 in the morning or whatever. She didn't see what was going on. She was in bed, like, and I'm like doing this, and she was like, whew. I was like, looking around like, I gotta check this out. Can I turn on the light? That's a clot, all right? None of this golf ball raisin. None of the raisin. Even a grape. Eggplant. I'm not sure that story was relevant, but I told it anyways. In my clinical group, somebody was asking, I'm trying to remember who it was, asking about what blood kind of bleeding is normal. That was you, right? Yeah. Here's your picture. So if you have saturated a pad in less than an hour, not a little panty liner, we're talking one of those big mattress-like pads, that's a large amount of blood, all right? Large, heavy, excessive. These words, if they are used to describe the amount of bleeding, I repeat, large, heavy, or excessive bleeding is never normal. So say there's a question on a quiz that says a patient is having large bleeding, whatever the question says. You can bet there's something wrong with that patient. So continue to monitor or leave them be or whatever the answer that you want is wrong. I'm here to tell you, large, heavy, excessive bleeding, not normal, needs to be addressed. All right? Find out, is it a tired uterus? Is it a confused uterus? Is it a pushed around uterus? All right?
Would you find that out first before consulting with a doctor?
I certainly would.
Okay.
Yeah, then we're going to go into, very shortly, we are going to go into some scenarios. All right? So large is not good. Boom, boom, not good. A moderate amount in the first 12 hours or so is perfectly reasonable, maybe up to even 24 hours. All right? Following that, we would expect a light, small, you might hear it called small and scant. just a small amount, like in an hour's time. When you are assessing the bleeding of your patient, it's always good to ask, when was the last time you changed your pad? Because you might be seeing 20 minutes worth of bleeding, or you could be seeing 2 hours worth of bleeding. Seems like a very reasonable question when you put it that way, doesn't it? And as I mentioned, the bleeding, the blood pooling in the vagina with those that a gush or possibly a small clot coming out when she finally moves, perfectly normal. Excessive spurting of bright red blood, spurting, all right? This is not an old, tired, confused, pushed around uterus. This is a tear somewhere in the vagina or the cervix or something that wasn't repaired and is bleeding, actively bleeding from a blood vessel, all right? So what you're gonna find in terms of scenarios, you're gonna find some excessive bleeding, right? Bright red, it's gonna look probably fresher, the blood is fresher. And you're gonna go to feel that fundus and it's nice and firm, right where we would expect it to be. So you're putting all the pieces together. What should you do? Should we continue massaging a firm fundus where it's supposed to be? No. We're gonna call the doctor. You're gonna assess, find that it's firm, and then call the doctor. Because it's not a tired, pushed around, confused uterus. It's an active bleed from an unrepaired cervix or vagina, all right? You see heavy amount of bleeding. It's maybe bright, not sure what's going on. You go to feel the fundus, and you find it mushy or boggy is what we call it, not firm. What are you gonna do? Massage the uterus and reassess. Is that working? We might have to turn up the IV rate a little bit if there's Pitocin in it, or get an order for some of that other medicine. All right. You see some heavy bleeding, you go to feel the fundus and it's up and over to the right. What are you gonna do? Have her void. And massage and reassess after the emptying of the bladder. Do you see the difference between those scenarios? If you find a fundus that's not firm with heavy bleeding and you call the doctor's gonna say, well, did you massage the fundus? Yeah, I wouldn't recommend calling the doctor before massaging the fundus. I'm here to tell you. But if you continue wasting valuable time massaging a fundus, when what you need to do is either empty a bladder or call the doctor sooner because it's a tear somewhere else, I don't recommend that either. I want to make sure that's very clear to all of you. Yes. Good. It might come up again. Did I mention large, heavy, excessive is never? Foul odor may suggest infection. Persistent lochia rubra. So that dark, normal process is that the lochia lightens in amount and color as the days progress. So say a woman is day 8 and she's still having dark red bleeding, and it might be a confused uterus. It's just not like that confused, but still a little confused. That's probably needs follow-up in the doctor's office with an ultrasound to see if there's anything left behind, all right? This wouldn't be a hospital thing because we'd expect to see rubra that whole time, but like I said, a week out and still that dark red bleeding, not so good. Now we talked about the goal is to prevent postpartum hemorrhage. What is a hemorrhage? A hemorrhage is, there's early hemorrhage, and that's within the first 24 hours of birth, and then a late hemorrhage is any time within the postpartum period, all right? 500 milliliters of blood or more for a vaginal delivery is considered hemorrhage. 1,000 milliliters or more for a C-section, because there's some, extra bleeding from different sources for a cesarean. Okay. Now, I had a patient. Was me and just one doc, because that's how we rolled back in the small community hospital with no, low risk patient, She was I think the only thing that didn't make her low risk was, I think it was her 5th baby. She delivered, the baby was a little stunned, I think, more than anything. So I was, getting the baby to breathe. And as I'm doing all of that, the doctor says, I need a little help over here. And the baby's doing okay, and I turned to see what was going on, and I could hear the blood rushing out of the woman. Not hitting the pan beneath her. I could hear. This is a solid 24 years ago. And I still remember the sound of blood rushing out of a human being's body. I didn't find that funny at all. That's a lot of bleeding. That's a postpartum hemorrhage in a very short period of time. That's an early postpartum hemorrhage. Postpartum hemorrhage might not be that obvious. It's just maybe a moderate amount of bleeding that has gone on for 5 days. That could still add up to 500 milliliters of blood. That's a late postpartum hemorrhage, okay? Either one, it's still a significant loss over time. There's a good picture for you. Episiotomy is the actual cutting and repair of the perineal area. Oftentimes it's midline, going straight down in the, you know what the perineum is? We have a lot of different names for that particular area. My most favorite that I learned last semester was the fleshy fun bridge. I'm sorry to have videoed that. I thought that was a lovely phrase there. It's the bridge, if you will, between the vagina and the anus. Fun, apparently. So the cut is oftentimes midline, right down between the two holes. Some doctors or practitioners do a medial lateral episiotomy, which is just slightly at an angle to the right or left. Then the subsequent stitching of that area. So here or off to the side. Yeah. Sometimes there's a spontaneous tear that needs repair as well. So doctors will do what they feel is best for the patient. Some doctors will always cut an episiotomy because they feel like a nice clean cut and repair heals better than a spontaneous ragged tear. Some will, some say that a tear might not be as deep as an episiotomy, so that it's not as significant a breach in the tissue. They all have their own opinions. Whatever their opinion is, episiotomy is meant to hasten the second stage of labor, the pushing. So maybe a baby is not doing well. We have a fetal heart rate that is tanking out, and that baby needs to get out. We need that baby out. They might cut the episiotomy and get the baby out sooner. Medically indicated by all means. Otherwise, it's usually their practice and what they have kind of grown up doing, what they feel is best for their patient. I'm not judging them one way or the other. Either way, it's an incision, right, that we need to assess for healing. We will assess for redness, edema, ecchymosis, drainage, and approximation. Anyone heard of RITA in terms of other incisions? We will check for that for episiotomy, and we'll also check for, in a abdominal incision for a C-section. All right, we just got to make sure things are healing well for them. The other thing I like to add to this assessment is how well are the pain medications or measurements that we're providing, how are they working? Okay. Ice pack. First 24 hours, we're going to put ice on it. All right. Ice is it helps with comfort. It helps with swelling. Back in my day, we used to fill a rubber, because that's all we had, rubber glove with ice, and kind of stick it in the, like underneath a pad in their underpants. That was our ice pack. I imagine it was a nurse who invented the modern ice pad, peri pad. So it's, I don't think I will ever take this pad for granted. I weep thinking about it. It is a pad that you pop and shake, and the pad itself gets cold. I have one on right now. You know, it's just the end of the, you know, the heat. Sometimes I was really excited about class. I just wanted to stay cool for y'all. And they're just really good things. The fresh postpartum patient probably appreciates these as well. It's an absorbent, cold pad for them to use. And no, I don't have one on right now for anyone who is taking me seriously. All right, so first 24 hours, ice. I repeat, 24 hours, ice. Just like they say, like injury, like ice for the first day, heat after that. Heat is really what we do expect. We want, every time a patient gets up, we want her to use the peri bottle. It's a small squeeze bottle about this big, soft, clear plastic usually. We put warm water in it. You know, it's tender area, whether there's stitches or anything, and there's bleeding and stuff. We want to keep it nice and clean. So warm water, squirt, it's kind of a bidet, right? Squirt the warm water, just pat dry so you're not having to like get in there real invasively to keep yourself clean. And we encourage using that for as long as is comfortable for them, but definitely while they continue bleeding. All right. Change a pad every time you get up to the bathroom, even if it's a small amount. That keeps the area clean as well. Sitz bath. Has anyone heard of a sitz bath? Sitz baths are also awesome. They are like a basin specially made for this purpose that actually fits on the toilet seat, not the seat. It seats up and it goes on the toilet itself. You fill it with warm water. There's some bag, like almost like an IV bag, with a clamp that you can put hot water in there, and like if the water gets cool, you can like refresh the warm water so you can stay on there long enough, whatever. It's warm water soak, basically, for your hind end. That's pretty cool. Now, you think, why not just get in the tub? Well, we don't recommend tub baths for the first 2 weeks, but a tub is you're sitting right on hard porcelain. Ow, ow. I don't know. That hurts, in my opinion. This, your hind end is floating. Floating, lovely, warm water. It's lovely. What it does is it promotes circulation and healing and comfort, all right, for an area that has taken a hit. Some non-postpartum women, even guys use this, especially if they have terrible hemorrhoids. They soothe the hemorrhoids, they promote circulation, and do help with hemorrhoids as well. Some people just use it to relax. In fact, every Saturday night. All right, call it Sitz Bath Saturday. Folks, you can email me. And if I answer you right away on a Saturday night, guess where I am? Yep, sitting on my sitz bath, checking my email. All right, just keep that in mind. It's been 26 years using my sitz bath. All right, the cervix. The cervix needs to kind of get back down to normal too, right? I like to consider the cervix like a scallop with a hole drilled through it. I mean, I've never seen bacon or anything like wrapped around it or anything, but to me it looks like a scallop. Obviously that hole widens and opens up to let a baby out. Following the delivery, it's kind of a beat up, bruised scallop, but nonetheless still looks like a scallop. So we have to go from this to this, all right? It takes about 2 weeks to kind of let it get back down to the normal scallop that it was.
You make me want to be a vegetarian, but you already said eggplant.
I'm sorry.
Just on
Egg.
vegan.
Oh yeah, vegan. Yeah, no, vegan. Not. Yeah, because the cheese, the cottage cheese. Is anyone keeping track? What do we got so far?
We got cottage cheese, we got eggplant, we got scallops, all things where none of us are eating ever again.
And I'm here to tell you that for those who really love scallops, you're going to eat them anyways, but you're going to think of me. 4 years from now, you're going to be sitting down to a bacon-wrapped scallops or whatever, and you're going to damn that Libby.
You said something about nipples looking like raw meat.
Raw meat, see? That's why I don't eat meat really too much. Hey, somebody needs to keep track of all these foods. All right, the vagina. Just get over it. I'm going to say vagina solid 18 times every class at a minimum. All right? Vagina. There, I've said it another time. We can 3 or 4 times already. Vagina. If I was teaching another kind of class, that might be inappropriate. But here we are. The vagina may be edematous, bruised, with small superficial lacerations, like rug burns. Yeah, I know. Have you ever gotten a sliver? Not a sliver, a paper cut, right? That's pretty much that. Or have you ever gotten like a rug burn, like a rub of the skin that there's nothing to stitch, like it's not a deep cut, but those burn. Yeah. Sometimes those hurt more in the first 12 hours, especially the first time getting up and voiding, than an actual, like, repaired cut. The vagina is loaded with all these rugae, however you want to say it, are all these folds in the vagina, which is what allows it to expand to this amount of space that baby needs to come out. That's why I think it's an amazing part of the body. All right. So it takes a little while. In fact, it takes about 3 weeks for it all to kind of shrink back down and heal, get back down to the new normal. The new normal. Okay. A breastfeeding woman, because a lot of it has to do with hormones too, a breastfeeding woman might feel like things aren't progressing and healing quite as well as a non-breastfeeding woman, simply because of the amount of estrogen. Well, actually, it's the prolactin that we need to create the milk that keeps estrogen levels low. So it's kind of estrogen related. Low estrogen leads to vaginal dryness, and so it just doesn't feel like things are healing well. But it's the low estrogen level. So if a woman says, I think something's wrong, I'm not healing very well, and if she is breastfeeding, it's appropriate to just say, use a little lube. That might help you feel better if you are concerned about painful sex. Muscle tone, never fully restored. But you can keep trying.
Do they advise patients not to?
I advise patients to wait till your 6-week check. But reasonably, we say until you stop bleeding. It's been 26 years for me. It's probably led to my divorce, now that I think about it. I'm just kidding. But some people just are scared and they want to make sure everything's healed up nicely. And so giving them permission to wait 6 weeks until your 6-week check with the doctor or practitioner is perfectly reasonable. But thinking about that open wound site that's bleeding, probably shouldn't introduce anything from the outside up in there while you have that open wound. So the advice to wait until you stop bleeding before you have sex is also a perfectly reasonable advice. If a woman's not breastfeeding, things tend to progress a little further for her in terms of feeling like she's healing. Breastfeeding and the hormones associated with it can affect ovulation. In fact, it pretty much prevents ovulation. Pretty much. Not all of that, right? All it takes is a slight change in routine. Maybe the baby sleeps a little bit longer at night. Maybe you pumped instead of nursed because you're back to work, right? Breastfeeding is not an effective form of birth control, all right? However, if you are full-time breastfeeding regularly, it tends to assist in preventing pregnancy. And not an effective method, but nonetheless. Non-lactating women may get their period at like 4 weeks out. So what does that mean? They're doing 2 weeks out. Ovulating. Yeah. So you might want to have sex after you stop bleeding, but guess what else you're doing? Popping another egg off, right? We don't want that. And generally, I've had women call me quite frequently, and it makes perfect sense. I stopped bleeding like 2 weeks ago, but now I'm bleeding again. Like, I feel like, and that was a question we say, if all of a sudden your bleeding increases, like during the lochia time, there might be something wrong. Or maybe you're just pushing it too much. Maybe you're doing too much. Quiet down a little bit, rest and see if it stops. So a woman will say, I stopped bleeding. A week later, I start bleeding again. What's this about? And I ask a couple of questions, and I say, congratulations. You just got your first period. They're like, oh! But that's how quickly it can return. Ovulation returns too, and we don't know about that until we get the period and realize, oh no, 2 weeks earlier I already popped off an egg. All right, so that's all I'll say about that. In terms of, do you guys need a break? Show of hands? Anyone? What do you want? Okay, let's take a break for a minute. We've already been talking for an hour.